Well, good morning or afternoon, everybody. It is my delightful pleasure to introduce Jack Jordan here. Jack is a nationally recognized expert in patient safety and quality improvement with extensive experience in achieving large-scale results, including designing of Eisenberg award-winning harm reduction programs, a proven track record of capturing essential data to plan, develop, and implement measure to achieve real-world results, a dedicated and passionate leader who empowers peak healthcare functions via proper planning and management. Jack and I met while working together at General Motors Powertrain Group and collaborated there over a number of years on helping to facilitate Deming seminars. And we worked together on creating the Deming 4-day seminar for videotape that was contributed to the Deming Institute. I think some of the projects that Jack's been involved in healthcare, I think, are really quite inspirational, and I'm excited to hear what he has to share with the group. I think normally we do kind of a quick run around and everybody introduces themselves. Is that correct, Bill? Yeah. Okay. I guess I'll start. I'm Ian Bradbury, and I'm President, CEO at Pico Services.
Bill Bellows, the In2 InThinking Network, and I'm here in Los Angeles.
Yoshimuki, retired engineering manager, director from aerospace, retired living here in Thousand Oaks.
I'm John Lenhart. I'm a consultant for Flowsess, and I'm on Into It now with the marketing division part.
Mike Gaethel, leadership and continuous improvement consulting.
That it?
I had to drop from the meeting, but I think we're introducing ourselves. I'm Dirk Van Putten, Quality Assurance Manager from Monolithic Power Systems Integrated Circuit Semiconductor Manufacturer.
Well, welcome, everybody. And Jack, I think we're ready for you to launch.
All right. Well, I'll start off with, I'm Jack Jordan, and, thank you, Ian, for the nice introduction. But Ian mentioned that we'd worked together at General Motors, so you might be scratching your head saying, well, how in the hell did this guy get into healthcare? So that started back in 1997, and it was an experiment to kind of bring people who had kind of experience in quality improvement and Deming into healthcare as an experiment, and so I started at Henry Ford Health System back in October of 1997, and have been working on clinical quality kind of programs ever since, even though most of the work I've done really has been around, clinical problem solving, even though I'm not a clinician. So it's been a fun and interesting ride. Henry Ford Health System designed a comprehensive harm reduction program. Our board at the organization said that should be their top priority back in 2007 or 8. So I got tasked with both designing the comprehensive harm program and also figuring out how to measure it, since that didn't really exist at the time. Well, still doesn't really. And coming up with our plan of how we're going to do that, I got to have a meeting with Don Berwick for about an hour and a half, going through how we were trying to attack everything you could about harm, not just one or two things, and how we had a comprehensive program, and asked him his advice of how we could do better, with what we were doing. And that led to, in 2010, when he became the administrator for CMS, he reached out to me and sent me an email that I had coming totally out of the blue, saying, would you be interested in coming to CMS and running a large patient safety program? So that's kind of how I got into what you're going to see here. This was called the Partnership for Patients. It was part of the Affordable Care Act. It was actually Section 3025 of the Affordable Care Act. And it was funded with $500 million to engage all the hospitals you could in the country around patient safety topics and to try to reduce harm at scale. It was not a program that was intended to be research. What we were trying to do is accelerate the adoption of known best practices and get that to be done reliably, again, at scale. So $500 million. The goal was to have a 40% reduction in avoidable harm and reduce 30-day hospital readmissions. I got the little things in the way. I don't remember off the top of my head what the percentage was back then. So this started, the contracts were released in early December of 2011 to 27 different contractors across the country. And I'll go into a little bit about that. They tried to recruit as many hospitals as they could. And they got a little over 3,700 of the 5,000 hospitals in the United States. And they also represent about 88% of all the discharges in the country. So pretty good scale of getting there. CMS, the Center for Medicare and Medicaid Services, led the program, and they had weekly meetings with other federal partners across Health and Human Services. We had HRSA, which is the Health Resources and Services Administration, which works with rural hospital care. They also do all the data about where there are shortages of types of providers in the country, and they've worked a lot with rural opioid kind of things. AHRQ, which is the Agency for Healthcare Research and Quality. They helped design kind of the tracking of the system. And then some of the programs for seniors and things like that around there were at the table and working with us. And the CDC was there. So it worked to try to get alignment across the existing programs and help us kind of work together in what we're doing, with kind of one common front from HHS. I think HHS was very cooperative across organizations at that time. That might not be quite the case today. But this was under Secretary Sebelius at the time. So we recruited also partners. This was a public-private partnership. So we recruited partners from across healthcare to be aligned with the program, and we really wanted to engage them in the work, everywhere we could. So we had the American Nurses Association, and they have a group of like the 30 different specialty nurses, nurses for ER, nurses for the OR, nurses for ICUs, it keeps going on and on. They were very engaged with our work and, in trying to involve and align with what they're doing. We also kind of help them encourage kind of promoting some of the things they do. They have a national database of nursing quality indicators that a lot of hospitals participate in, and we certainly highlighted that to some degree. Physician groups, we had the Society of Hospital Medicine was very engaged. They aligned a lot of the work they were doing with the kind of hospital patient safety stuff we were doing. The American Board of Medical Specialties was also really helpful. We had a failed project with them where we were trying to fund them to align what's called the maintenance of certification with this work, so that when someone's a board certified, fill in whatever the specialty is, they have to maintain their certification by doing certain things. Some of it could be going to seminars, some of it doing projects. We were trying to get to work with them to align that so that the physicians could get credit for their maintenance of certification by being heavily engaged in doing some of this work. And just for a variety of reasons, we weren't able to really get that done, though they did it to some degree anyway, even though we didn't give them the funding to really do it lockstep. Surgical safety, we brought together the American College of Surgeons and the nurses, the Association of Perioperative Registered Nurses, and anesthesiologists. And all three of them, they did a great job of crosswalking all the different things they had around patient safety and helping align them, but then also, sharing and making that available. They made a beautiful website that had all the different things really well organized, as far as to get to any of those materials. Unfortunately, it was hosted as a federal website, which makes it so it was a little more difficult for people to get to than we would have liked for, hospitals. But the contractors found it very useful, and they could go through the pain of keeping up a password and such. I think that's gotten a little better with government websites, but at the time it was very somewhat challenging. Medication safety, we were heavily involved with the Institute for Safe Medication Practices and their work, and then probably more engaged with Society of Health System Pharmacists. They really were working on medication safety, and we helped align with what they're doing and kind of fuel that. We pulled risk managers into this too, so they were ASHRM is the organization there. We spoke at their national conference and had a lot of good engagement with them. And then obstetrics and gynecology, we had the American College of Obstetricians and then the College of Nursing Midwives, and they were doing a great job. I see there's some stuff in the chat. I probably am missing something. Huh?
No, I was just saying I'm surprised at how few hospitals there are in the United States. There are 20,000 communities. I'm just 5,000, maybe 6,000 hospitals seems low.
No, there's only about 5,000, and 1,600 of those are critical access hospitals that are really small,
Wow.
small rural access. Yeah, and the skew of that kind of stuff is very interesting as well. That there was a big collaborative in the state of Michigan working on central line infections, and 5 hospitals have over 40% of all the central lines in the state of Michigan. So the big hospitals are so different, that they can dominate some of these topics.
Yeah, wow. Just so you know, Jack, I worked with a company that built devices to prevent hospital-acquired infections. It was actually to detect subdermal moisture accumulation to prevent pressure wounds in hospitals. So I'm very interested in this topic.
Okay, great. Yeah, we'll talk about pressure injuries in here a little bit too. One of the things that I think CMS, the federal government, did with this really well was really encourage and invite the voice of patients in this. So every contractor had to have patient and family advisors involved in their program. And every webinar that CMS put on had a patient point of view in the commentary. So we would really, scour the country finding patients that had relative experience in the topic we're talking about that day, and they might share their story, and then they would comment at the end about what they liked or thought there were opportunities for improvement of what was presented. And to some degree, they were involved in the design of the program. I think we might have been able to do better with that, but I think we tried and had a lot there. And we also encouraged 5 things of hospitals. We tried to encourage them to have patients as representative on their boards. Now, I think that's illegal in New York State, but in most states it is legal. So they had an excuse of not making much progress on that since it's against the law in their state. But I have no idea why it's against the law, but that's the case. And then also having communication when someone's having a planned procedure, of trying to have better communication with the patients of what to expect and how to, prepare for that procedure. Having nurses hand off at their shifts in front of the patients, discussing it with the patient there, hearing it is something we were encouraging. And then having patients on quality teams where you could, and then having family councils for the hospitals in the hospitals. We wanted to have hospitals try to do all 5 of those things if they could. And we did have some tracking about the progress of how much, when we started, many hospitals might have 1 of the 5 or 0 of the 5. And, by the time, when we were done, we had a lot of hospitals that were doing 3 or 4, or, a couple of them that, had done all 5. So the scope of what we were doing is pretty big here. You can see there's 12 types of harm we were trying to work on. With OB, we had early elective deliveries, and this is delivering a baby before 39 weeks. That there's no medical reason you have to do it early. 40 weeks is normal term pregnancy, but to give drugs to induce labor when there wasn't a medical reason, that was a pretty common practice in 2010. It was kind of disgusting to think how many obstetricians who thought they were wonderful people, that if they were going on vacation, it was much better to endanger the baby, delivering the baby early so that they wouldn't have to have their partner deliver. That's not really how people talk anymore, but at the time this started, that was common thinking, which is appalling. But and then OB other, and as this program went on, it left the Center of Medicare and Medicaid Innovation and moved over to Medicare proper. And those things had to be jettisoned at that point because Medicare doesn't have the legal authority to work on those things, where Medicare and Medicaid Innovation did. Medicare pays for about single digits of births each year because, most of their people are over 65. It's only going to be people who are on disability that, rarely are there. Readmissions was a key thing, and that's where a lot of the money, when we show that, comes up with on here. Adverse drug events, we worked at 3 different types of kind of drug categories that we were focused on to a large degree, and just a few areas on some other topics around there about drugs with the elderly, but we didn't spend, that was not really our focus. A ventilator-associated pneumonia, which, interesting, had kind of a curveball happen to it during this program. The CDC kind of revamped how they looked at it and moved it from being just purely an infection kind of a measure to one of it triggered off if a person was on a ventilator and stable and they needed, their oxygen needs went up, that had this broader kind of thing, which I think was a long-term good thing. But I think it took hospitals a little bit of time to get their head around a lot of the things in their new definition of what they were working on was more focused toward respiratory therapists, and before it was like totally owned by infection control. So there was some facilitation that had to go on to kind of get people to change their mindset and think about this kind of broader way of looking at harm, which I think was a good thing in the long run. But it was one of those kind of things that caused a hiccup when it first happened because people were trying to get their head around, wait, we don't care about this. We're infection control, and that's maybe not the right attitude, but it wasn't in their skill set. And then to kind of broaden it and get the respiratory therapists kind of saying, oh yeah, this is really cool. And then bloodstream infections, which is kind of, one that people think of as the big deal in hospitals. Again, it's big deal in big hospitals, small rural hospitals. Once they put a central line in you, in many cases, that's kind of a reason to say, we're going to transfer you to a big hospital. And then blood clots, venous thromboembolism, that's both in the legs and the lungs. It's one of the number one reasons people suddenly die in hospitals, and working on how to manage that. Urinary tract infections, when they're putting a catheter in people, and how to reduce those. Pressure ulcers, you can see there in the hospitals, and how to, consistently turn people, make sure their mattresses haven't broken down. A lot of work there. And then surgical site infections was here, and again, we had really good engagement from all the organizations that cared about that. Falls, and then C. diff, C. diff is a diarrhea you get from an organism that is in your gut, and it's incredibly difficult to kill. You alcohol wash on your hands doesn't kill it. You have to use soap. It can live on surfaces for ridiculous amounts of time, and you usually have to have bleach type things to do things, so it can damage equipment, but it is the number one kind of hospital acquired infection in a hospital, and can be devastating. People can have to have surgery and remove part of their colon from it. So it's a big deal, and it's also one that's dropped the most in recent years too. So
Jack,
go ahead.
What were the criteria for selecting those forms of harm versus other alternative types of harm?
Yeah, so two kind of things. One, they're the most common, and two, all of them did have some level of known processes that could be put in place that could reduce them. So we weren't going to choose anything where we didn't have a change package to put forward to say, we had to know what to teach people to do. And then we had to have some research to say that, you can make a major impact on them. So those were kind of your criteria.
I didn't see medication errors in there. Was that purposely omitted?
No, adverse drug events are there, and it's for three types of drugs. And that's in the slides later, a little more detail about that. So
I was thinking more along the lines of giving the wrong patient the wrong medication.
Yeah, that was less of a focus. It was really more about, using insulin or drugs that, for diabetes, blood thinners, the 3 kind of categories of drugs that are most harmful to worry about. So this is an interesting thing. It was very controversial, and in fact, we had an outsider kind of really attack us for this. And so this is kind of interesting. We had to have a way to measure this. And one of the things that was just wonderful in this, it was just a godsend, was that there's existing measure that the federal government does about 60,000 chart reviews a year as a validation for a different program. But that gives you a very firm, thorough method for tracking 22 different types of harm. It was called MPSMS, the Medicare Patient Safety Monitoring System. And we had that, and so our contractors had nothing to do with it. They couldn't touch it, and so it wasn't relying on them turning in data. But then the next phase that came out of that means each contractor could do whatever they wanted measuring, and we didn't make them all do the same thing. And that was massively controversial. And people, especially people who were researchers who kind of were thinking that you're trying to prove these things work, which we weren't. We were trying to accelerate their adoption. Really criticized us for that. And let me explain why you didn't want to do that. It forces you to the least common denominator for measurement. So you might have one that's the least useful way of measuring it, but it's the one everybody can do. But you do have subsets of hospitals that are doing things that are much better than that, but you can't force everyone to do it. So one example of that is for pressure injuries. The American Nurses Association's NDNQI, National Database of Nursing Quality Indicators, they have a wonderful method for measuring pressure ulcer rates, but it's an audit of everyone in the hospital on one day on a sampling kind of a basis. It's very labor intensive. You get much higher numbers from it than you get from using billing data, and you learn a lot more from it. So we wanted to encourage the contractors there to, if you have a subset of hospitals that are, doing that, they have to do that if they're wanting to be a nursing magnet hospital. And a lot of academic hospitals do it, even if they're not magnet, because you want to use that for lessons learned for all the hospitals, even the ones that aren't doing it. So that's kind of the thinking there. We don't want to throw those things out that are better just because we want to have everyone be common. And we wanted to get as many hospitals participating as we possibly could. And we didn't want to have, if we're forcing people to use a better measure, that being a barrier that then people walk away and aren't engaged in doing it. So again, we wanted to have this be representative of the nation as much as we could. And so having that independent measure outside of this left us that ability to do that. That was, much, much safer, I think, and help people get a lot better alignment for what's going on there. Another example of that would be for surgery improvement. Hospitals that participate in the American College of Surgeons National Quality NSQIP, National Surgical Quality Improvement Program. Not all hospitals do that, but the ones that do that, they have really good data. They're doing, chart reviews on 40 cases every 8 days, and they're very thorough with 130 some variables. Lots of stuff you can learn from it, and we want to have all the hospitals get the benefit of learning from that, even if they're not going to be, participating in it. You can have people that can really talk through some of that and help people understand it. So alignment of measures was not required. And believe me, we got beat up for that. And I'm a total advocate for why we didn't do that. And I think it was the right thing to do. Even though, like I said, Peter Provost ripped me a new one and published it saying I was an idiot for it. But that's, neither here nor there. So how is this different? These contractors were mostly new to federal contracting. A lot of them were state hospital associations or some other types of groups. And they were also people that had a history of kind of passion related to patient safety, which I think was a huge value to us. We also, I think the management of this program was somewhat different than how the federal government had managed a lot of this kind of stuff in the past. That we really worked hard to work with the contractors to kind of say, if you don't succeed, we don't succeed. We're in this together. We want you to succeed. We're not here to beat you up and pick you. You are going to push you hard to try to achieve as much as you can. And early on, I think, we started to run into a little bit of a wall on that, where some of the contractors were starting to go, well, what do we have to do here? What do we have to, and to try to stay on message with them that the issue isn't what's the minimum you can do to legally fulfill your requirement. The issue is what's the most impact you can have with the resources you're being given, and keep tapping into that, passion these people already brought to the table when they came to this, for working on this. And I think it worked. Well, you'll see the results that, we come out of it. And there's also another burden we had to get over, a hurdle. And that was a lot of people came to this saying, well, we have to focus on just one or two things, in each hospital. We can't work on everything at once. And again, that's another one where I'm an outlier of no, you actually have to work on everything at once. Hospitals shouldn't just choose one or two things, but the pharmacists might be working on a handful of items that are important to them. The ICU might be working on different things that are important to them. The obstetrician, but mom and baby stuff, again, they might be working on bleeds for the mother. They might be working on the early elective deliveries, and they're segregated out as different kind of things than most of the hospital, and they can focus on that. The med surge floors might be a lot more interested in urinary tract infections than, where the ICU is going to be looking at bloodstream infections and pneumonia, pneumonias. The emergency rooms might be focused on sepsis, and so they all have different things to work on, and they can all be working on them separate from one another at once. And if each one of them are making a little bit of things, and even, your house cleaning, if they're working on reliably making sure that, the things they miss cleaning a room, like doorknobs or light switches, are always reliably being cleaned, or they're making sure that they're trained well, to clean the things. Those kind of improvements matter. They're a big deal, and they can be working on that and not have anything to do with the placing central lines and patients and the reliability of that. So the mindset was everybody has something to do, and if you've got everybody making a little bit of improvement, it adds up to gigantic changes, across the thing. So we also change packages, the idea there of finding what works and get more of it. So one of the advantages this program had, and I think they made mistakes at CMS after this, is that this involved all the hospitals. And the last two rounds of things they've done at CMS, they tried to target on hospitals that needed help. Which is a problem because the people who are already successful, they are the best faculty you can get. Having them involved and bringing them up to say, well, this is what we did to get past that. They're fantastic. And having them at the table and then letting them brag and show off about how, good they're doing. That's a key, mantra that was going on this. So, each contractor kind of developed their own kind of change packages, and we kind of shared things across them, to help advise them to, how they could be better. They also had, their own webinars for hospitals and their support for hospitals that were there. CMS kind of hosted, similar kind of things for the contractors, and occasionally the hospitals could be, and those. And they also had they independently came up with methods to assess the needs of the hospitals. They were all a little different, but again, we tried to share across them, best practices or what we thought was really good one was doing and to do that. And then also we tried to bubble up from them the success stories of, places they were doing that were doing exciting stuff. And also focused on that this program was not research. It was a program to accelerate dissemination. And that is different. We're not trying to prove these things work. It's already been proven. We're just trying to prove or help you figure out how to do it reliably in your hospital. So this program was very complex and dynamic. You've got 3,700 hospitals and 27 contractors, and the contractors are all kind of different. We partnered with all those national organizations, and they were enthusiastic and helpful, and helped kind of pull in different players to this independently from the hospitals. There was high expectations for results. I mean, this is really kicked off by Dawn Berwick and Secretary Sebelius had monthly updates on her kind of thing, and she really wanted to see that all the parts of HHS were engaged and supportive. And caused real alignment from the federal agencies, which I was told there when I was there at the time, that they'd never seen the different parts of HHS work together like they did with this, which was great. But I wouldn't know if that's true or not. I had no other expectation. This is the only way I ever saw it. But I think there was great leadership at HHS at that point that was doing that. And there was a lot of energy and excitement around it, I mean, and we got past a lot of historical infighting between, CDC and AHRQ and whatever. They all kind of had their little turf wars, but we were very good about getting past that. We also tailored this program to the needs of the hospitals in niches. The rural hospitals are very different, and HRSA has a lot of experience working with them, and they really led a very engaged work group about that, about what are the things that we need to worry about in rural hospitals that are different, and how do we find success stories in the rural hospitals that they can come from, because the big urban hospitals, the rural hospitals don't gain much from hearing from them. They really see themselves as different, and they are. We encourage patient and family involvement in this work, at every level. Most of the contracts were regional, like the state of Michigan, had one, and oops. A lot of these, oh my God, I'm sorry. I need to update Java. And then other ones, there was one contract that was all academic hospitals. So that they again have there's a lot of things that are very different for them. And not all academic hospitals, like the hospital I came from in Michigan, they really stayed with the Michigan group, not the academic hospital. But the University of Michigan in the state of Michigan, they went with the academic hospitals rather than the state of Michigan kind of group. Children's hospitals had a separate program. Again, patient safety things are very different in children's hospitals. And there was the children's hospital group was ran out of Cincinnati Children's. I think they had like 90% of the children's hospitals in the country. And a lot of the academic centers where they had kind of a children's hospital built into them, split off where the children's portion was participating with this and the main hospital, which again, the way the language of the legislation was written, that took a little bit of gymnastics on our part to allow, because it was kind of meant to be one hospital with one, contractor. And so in those cases where they weren't technically a different hospital, we did our best to kind of let that work. And then there was a group of the safety net hospitals that care for kind of the poorest and most vulnerable people. So again, a lot of tailoring to kind of to meet the needs of hospitals where they have different things, and that worked pretty well. I mean, it's not perfect, but it seemed to give everybody a place to be. And are people here familiar with the breakthrough collaborative kind of model that came from? I see Ian shaking his head. I know he is. And I see Mike Beck there. I imagine he is too. But this is really kind of, you think of a three-ring circus. This was kind of like having 27 different contractors all run 8 to 10 breakthrough collaboratives at once, and some of them, they came at it different. Some of them might be ICUs, and there's maybe 4 topics in the ICUs, and they're doing a breakthrough collaborative for that. And others might be topical, one topic at a time, trying to do this. So you had all these moving parts kind of going at once. And then you're also at CMS, we were trying to connect the different, things that were working from, each of the different contractors who were different to kind of pull this together. So it does have that look of, select kind of a problem and establish your team and your leadership and have a learning session about it and give some people time to work on it and come back and share what's working, what's not, and then go back and do PDSA again. It all had that going on, but again, it had it going on with multiple topics all at once in parallel, and then in parallel across contractors. But then we're trying to build the connections between them to keep it moving. So it was organized chaos in some sense, because you're trying to move so much and so fast, I mean, we only had, a limited number of years to kind of get this done, and trying to have that urgency to keep it moving and not have people, things. So, but I think that that's the whole collaborative model, of the breakthrough collaborative is, very powerful. But again, we tried to use it the best we could, but in this chaotic way of doing it multiple times together at once, So some examples, early elective deliveries was one that was an interesting one. So an early elective delivery is giving birth before 39 weeks, where you do either an elective C-section or you augment the labor or induce labor earlier than 39 weeks. Babies that are delivered that way, they have higher rates of neonatal ICU use. They can have respiratory problems or even higher risk of death. So doing it for no medical reason, there are medical reasons you'd have to do it early, but is hard to justify. So the partnership patients worked with ACOG and the March of Dimes and the College of Nurse Midwives to eliminate this practice. One of the things government can do very well is kind of be a host, to facilitate kind of bringing people together in the conversations. So we kind of brought them together with this to kind of, move this along. And then also with each of the contractors taking this on, with what their plans are in their local kind of communities. So what did they do? So the federal meeting convened, ACOG leaders and nurse midwives on changing the practice and their recommendations. And I got to be a fly on the wall in that meeting, and it was a lot of fun. The nurse midwives just completely just took out a couple of the ACOG guys by the knees because they were still kind of trying to defend it. And the nurse midwives were, this is nonsense. You shouldn't be doing this. It was really fun to be a fly on the wall and watch. But, I think it really kind of turned the thinking around. It was already starting, but it really, moved much quicker than. Then starting with the state of Iowa contractor, they got every CEO of every hospital in the state of Iowa to sign a pledge that they would no longer allow scheduling of deliveries before 39 weeks without an appropriate diagnosis. And then that kind of became a strategy that we spread to all the other, contractors to try to get that done. They developed education for the hospitals and for patients around, why you shouldn't do this and why we should, be moving things forward. There was feedback to the hospitals and compared them to their peers. So when you'd have like one outlier hospital that was doing a lot in a state, you could be showing it, wow, you guys are doing this 3 times as often as, these other places, what's the deal? Or also the other way around. Wow, this hospital has none. I mean, they just never do it. And sharing stories from hospitals about how they were successful with it, how they dealt with, the one physician that was really reluctant around it, and, helping those stories and strategies, again, it moved along. And here's kind of the data across the country for, non-medically indicated early term births. It started off, it was just shy of 12%. And when this kind of started, it started a little bit before here and then continued going down and down, and you're down to under 8%, within a couple of years. So, dramatic improvements in the rates, for this happening. So I think it was one of the early successes in the program.
Excuse me, Jack.
Yep.
I'm sorry for interrupting. It seemed like there's already a downward trend before your program started.
Yes.
So, is there any reason for? Was there some other activities going on before that to reduce the early deliveries?
Well, the March of Dimes got involved probably around 2010, 2009, and started, raising kind of the flag around it, and then, brought it to CMS and got it, added onto our plate as one of the things for us to kind of work on. So yes, it did go down prior to the program, and then we helped try to move it down further.
All right, thank you.
All right. And then the next kind of category I'll kind of go through is some of the infection control work. So everyone had developed change packages around central line bloodstream infections, catheter-associated urinary tract infections, ventilator care, Clostridium difficile, surgical site infections, and then antibiotic stewardship was in there too, both related to surgery and also just to trying to reduce the overuse of antibiotics in the hospitals. Shared lots of stories from hospitals that were successful and lessons in developing, highly reliable practices around these areas. The CLABSI kind of work just started off in Michigan in like 2006. There was a collaborative here that was funded, and I was involved in that as the quality director at a hospital, as one of the big hospitals. When it started out, the rate for CLABSIs across the country, the 10th percentile, the best 10 percentile was 1.7 infections per 1,000 line days. And then when that collaborative ended in Michigan, the state average for Michigan was at 1.7. So they had moved the state of Michigan down to the 10th percentile for rate of infections. And that happened prior to this. And then part of the work here was to try to spread that across the entire country to get that kind of reduction everywhere, because we were just coming out of that in 2009-ish, so 2 years before this. So challenge hospitals to adopt the practices, doing small tests of change, with what they're doing, and then sharing kind of the stories of what had worked at places. The professional societies were, I think, very aligned with this, and like I said, they helped develop a lot of the surgical tools for care. The anesthesia kind of came out with a whole program around improving surgical care that I think this really turbocharged to some degree. It was kind of, they were thinking about it, and then I think this kind of fueled them to thinking much broader. So we were coming at kind of a lot of the hospital infections at once. I guess we didn't. I'll show you the results of that kind of stuff here in a little bit too. Then medication safety, and we had, 3 areas of focus: glucose control, managing glucose in the hospital, anticoagulants, which there we were just starting the process of moving from people using warfarin to using the direct acting anticoagulants. So our measure for outcomes was looking at warfarin. It's a little bit harder to measure the outcomes with the DOACs. And we didn't have anything for that at the time, but that transition was slowly happening, and then opioids. And this opioids was really in the hospital. We were not working on outpatient opioids. And we probably were just starting to touch on reducing the use of opioids for acute pain. It was really safer use while patients are in the hospitals. In hindsight, I think the changes that happened just after this with trying to reduce the use of opioids in acute pain, especially for surgeries for patients that work on opioids, probably had a far more dramatic effect than what we did here, but it's still important, because this is all an evolution as time goes on. So with glucose control, we encourage kind of copying protocols with known safety, including kind of long-acting insulin. A lot of this is really in the hospital, getting people to be on a longer-acting insulin and not be giving them short-acting insulin over and over with every meal. We shared versions, for nursing units of how they were doing it in places that were working. We shared insulin drip protocols with the ICUs that, had known success of working. And then we had, stories of how to problem solve, the issues. And then one of the interesting ones was improving the timing of insulin with meal times, because one of the changes hospitals started to do, and they claimed it was for satisfaction with the patients, though really it's a budgetary thing. It's much cheaper to do. And that was letting people order their meals whenever they wanted. They didn't have meals come up to the floor all together at once, and delivered their trays to everybody. Your floor gets dinner at 5:15 or whatever, which that was very nice for these kind of protocols, because you could give people the insulin 15-20 minutes before the meal's going to come. You knew when it was going to come. But when patients can order it independently and they come one at a time for each different patient whenever they wanted the meal, that poses some real challenges with improving your timing of insulin reliability for the patients. So that was a real challenge to work through. And then also helping people share how they document the giving of insulin and the blood sugar results to make the results more clear. When I worked on this in my own hospital prior to this, it was interesting that we had the electronic data for people bottoming out and having low blood sugar, and it got dramatically better. But this was still with a paper record even before you had electronic medical records. But many of the people were swearing it was much, much worse. And what caused that is we organized the documentation so you could see what was going on really clearly. And before, you'd have to flip from page to page to page to see what was going on with people's blood sugar. So when bad things were happening, it wasn't clearly visible what was going on. So when we had done this, this was a runner-up for a Codman Award kind of thing with the success we had with it. We dropped, the low blood sugars happening. We dropped them by almost half, and we tightened things up very, very well. But again, like I said, since we redesigned the documentation, it made it so much more clear what was going on. It gave people the impression that they were seeing it. But luckily, that's one of those, we can pull every single lab and show you the data, with that. And I actually had an Access database with 3.3 million readings in it, that we used for that. But then anticoagulants, that's one of the other ones that are so important and so dangerous and important to deal with. Warfarin is essentially rat poison. When you poison rats, you give them warfarin and they have a massive bleeding stroke from thin blood and die. And we just give it to human beings in very measured, appropriate amounts. But you can see where things could go badly wrong if you get doses of it off. Pharmacist-driven protocols became kind of the rage in the 90s, and things got dramatically better when it wasn't individual physicians, writing a different order all the time, but passing it off to pharmacists. But again, that's a challenge in small hospitals because they don't have the pharmacists available to be able to do that. So tools were developed to kind of help rural hospitals do that much better. This was one that was really the Hospitalist Society was really engaged in and cared about and put passion into. And also then moving people from warfarin to the new style of drugs, was also part of this too that helped out with this. And then also tools with heparin, which is another blood thinner, the drip protocols and how to use the low molecular weight heparin. So that's another one too, where the price was starting to come down for the low molecular weight heparin. So people were switching to the Lovenox instead there too. So helping people do that and do that well. And then opioid use, again, like I said, our scope was probably narrower than it maybe could have been, though the people we were working with were in the hospital. So I think, a lot of the great work that happened with opioids later was, in an outpatient setting, or also reducing the amount of drugs used for treating pain from a surgery or an acute episode. But the tools included really training on pain questions, the dosing methods, and then safeguards for pumps, the pumps that people have in hospitals. There's a lot of they can be complex, and there's a lot of challenges there, and really going through how to program them and steal the protocols from one another that work better in this work is, I think, very important. So these are the overall results, and you can kind of see how much things dropped from baseline in each one of these. And the blue was kind of maybe some of that we talked about earlier, where things maybe went down before we started. Oh, I did. I think somebody's got a speaker on and getting feedback. But then the next blue one there is the kind of the first year of the program, how much of these things dropped. And then the lighter green was then, in the second year, how much things started to drop across these. And notice none of these had the bar go up. So in every single one of those areas, we saw improvement in the reduction of harm across the things. So I think that's just as a random chance, you're not going to have everything get better unless we were actually doing something. And then that method I told you about that was done with the chart reviews, independent of the work, that allowed us to have the contractors kind of measure things however they wanted. it tracks the 22 types of harm, and then they have a rotating sample of where the hospitals are pulled from. So you can kind of see the baseline kind of work there in 2010 and 2011. And then you can see kind of the pretty dramatic drop there. And then 2014 didn't seem like it got much better than 2013. But this is gigantic kind of moves, when you're starting to say you went from 145 events to 120 per 1,000 discharges. That's a pretty big move at scale. When you're saying this is what we did across the country, it's a random sample of hospitals in the country, which not all of them necessarily would have been a participant, but we had 88% of the discharges, so probably almost all these would have been in the program. But that's part of the thing that our mission was to drop the program for the whole country, to get the entire United States to drop, and we successfully did that. And so I was at the beginning of the work with the Office of the Actuary in the federal government to validate the results. And here's kind of the quarterly kind of trend on that data I showed there with the annual. So part of this too is you have to get with a program like this to be considered a success, you have to have the independent Office of the Actuary at the federal government go through the data and validate that they agree that it was causal. Here's where the big money came from. So this is the readmissions across the entire country for Medicare fee-for-service patients. It was running a little over 19%. It started down a little bit before. Now, the penalties for hospitals kicked in, I believe, at the end of 2010. So around here. I don't know if you can see my mouse moving, but and so things started to drop. Then there was a lot of desire from the hospitals because of the penalty money. They hadn't really figured out that the penalty money wasn't going to be as big as they thought it was going to be. So that was one of the things hospitals glommed onto right away that they wanted help with, they were really interested in, and the contractors really jumped into that. And you can see it moved pretty dramatically down. And this is one where the actuary was more convinced that the penalties from CMS had more to do with it than the support we gave. I think it's a both and. But what's interesting is the penalties for commercial insurance were probably even more onerous than the penalties for CMS. The commercial insurance stuff didn't drop near as much as this did, which is kind of interesting. But huge drop in readmissions, which again, that's what totals up when I show you the money that was saved. A lot of the money came from that. So this is what the cumulative savings for the program was done compared to a 2010 baseline that the actuary bought off on. So they said they gave us credit for $3 billion of improvement in 2012, another almost $8 billion in 2013 cumulative, and then the total from 2010 to 2013 was $11.9 billion in their first report from the actuary. And then a year later, when 2014 was added to it, and then they went back and kind of cleaned up the data a little bit more, kind of the semi-final results that came out was that there were 2.1 million fewer harm events from this program. It saved about 87,000 lives, and it was credited for $19.8 billion in total cost savings. So depending on which side of the aisle you were on, it was a great success that we spent $500 million and got credited for $19 billion in savings. Though the goal when it was put out was it was supposed to save $30 billion. So if you're on the other side of the aisle, you can say it was a total failure. And, that's kind of how divided up our country is these days. I'm biased, but I think it was quite the success. So that's the end of the story about partnership for patients. And then the next part of it's kind of a little more theoretical, talking about strategies for kind of helping accelerate change. So if there's any kind of questions about kind of the clinical program, this would be a good time to let me know. And None?
What is the view, would you say, of the medical establishment as far as these rates, having declined, but where they are currently? So, like the harm event, 121 per 1,000, so 12%.
Yeah. Yeah, and the QSRS is the name of the program that replaced that MPSMS because they reconnoitered it after that. One, to make it less expensive to do because they could take advantage of electronic medical records. So it does have a little bit lower number today, but I think people were there's way too much harm going on, in the hospitals, and when you include things like glucose control or, stage 1 pressure ulcers, you get a lot of things that are, there that, you'll probably never get rid of stage 1 pressure ulcers. They're just too easy there. I mean, stage 2, 3, and 4, those are bad. I mean, you should never really have those. So there's still room to go. And things actually have gotten better since 2014 in many of these cases too. They re-baselined the infection stuff in 2015, and I know they're just starting to roll out the 2022 re-baseline again. So every 7 years or so, the CDC re-baselines so that, the rates will go up to a adjusted rate of 1. And then, so the C. diff numbers right now are at 0.4. So there's been a 60% reduction in C. diff in the last, since 2015 re-baseline. So stuff's gotten better, since. And there's been iterations of this program kind of afterwards, kind of, trying to take things further. But I think, people realize there's still a lot of harm out there. During COVID, things got a little bit worse, and then, they got a little bit, they've gone back to where they were, a little better now. But interestingly, not everything got worse during COVID. The C. diff got better. I believe one of the things with C. diff that helped, though, is that in the end of 2019, soap that used triclosan as its antimicrobial was banned in the US. I think it's banned worldwide. So the antimicrobial soaps that people use now seem to maybe work better because it started getting better before COVID. At first, people were saying, "Oh, everybody's really washing their hands now because of COVID," and it's like, yeah, you can't maintain that for 3 years. I mean, people's behavior slipped back. So again, I would say the people working in healthcare are still saying there's way too much harm. But a lot of these things are dramatically better, and some of them, from quality improvement work, and then some of them from just evolving better things too. I think that the anticoagulants are less dangerous than what, we were using before. And, I mean, warfarin interacts with a million different things. If you eat a lot of garlic, it makes it far more effective and it thins your blood even more. And, you eat broccoli and it's less effective, so there's all kinds of stuff like that these newer drugs are better for. So things like that happen that, they're changing the technology. They're not necessarily quality improvement. So I'd say the person on the street working in healthcare says there's still way too much harm, but it's gotten a lot better.
Without getting too much into the details, I am curious as to the actuarial process that, arrived at these outcomes. When I'm looking at a cost reduction or cost avoidance program, one of the things I'm asked to do is to subtract any implementation costs. And I would guess that your $500,000 that was spent for the program would be one thing that would be subtracted. But there are both recurring costs and non-recurring costs to many of the solutions I've worked with. Were those differentiated for this program as well?
Not so much, because this cost savings that you're seeing there is really an insurance company's cost savings, not a hospital's. So the implementation cost was zero for the insurance companies,
Yeah.
So what the hospitals were doing and getting paid for wasn't, I don't believe, in there. The billion for the program the actuaries would have subtracted out for the government spending.
Okay. And this even 2014 is over 10 years ago. And I know you've addressed a couple of these subsequent baseline efforts, but is there any intention to repeat this, say, 10 years later?
It had iterations that followed. The next version of it went through like 16. And then around 2020, they had what was called the H-Quick program, and that ended. And then they've rolled it back to being like what it was before with the quality improvement organizations, which I think was a mistake. But so the 13th scope of work came out 8-9 months ago, but that combines nursing homes, hospitals, and some outpatient kind of stuff. It's underfunded by comparison, because you have a much bigger scope and it's even less money than what we spend on just hospitals. And the current administration, that AHRQ that was a key supporter for us, I just read yesterday in the paper, their staff has been reduced by 60% in the last year, and will fully probably disappear within a year or two. So a lot of the kind of organizational work within the federal government, this is not a high priority or even is under attack. I'm trying not to be overtly political in the comments, but
no, I hear you. I hear you.
Though patient safety traditionally is kind of a cross the aisle thing. No one's against patient safety work, I mean. I guess this only took 45 minutes when I did the first time. I kind of was a little more talking.
I wanted to talk a little bit about the boundaries of where the study occurred, if I may. So it sounds as though it's from the point of admission to the point of discharge. Would that be accurate?
Well, except for the readmissions, yeah.
Well, even the readmissions would be, there would be a point of readmission and a point of redischarge, right?
Yeah.
So a couple of the things that I experienced in the glucose management area were very troubling. I'm just curious as to whether or not you saw any evidence this was being addressed. In the case of a loved one of mine, there was a diabetic medical alert bracelet that was worn. Upon admission.
Okay.
The patient was suffering from a stroke. When I arrived at the hospital, they had a glucose drip hooked up to her and no evidence that she was a diabetic on her chart. So that was the first red flag. And I think the admission process itself is an important factor in some of the harm I've seen done anyway. So I don't know if that was included.
Yeah. Well, if they were on a drip, they were in an ICU.
Yeah, they were, of course, but,
yeah, the nurses would have a riot if you had somebody on an insulin drip on the med surg floor.
Yeah.
Yeah,
so,
our protocol though at Emory Ford, when we were working on that, if you were in the ICU, they went to the drip, and even if you weren't diabetic, if you were high, that's how they wanted to treat it.
Yeah, in this particular case, they put a diabetic on a glucose drip. That seems pretty counterintuitive.
Why would that be counterintuitive to put a diabetic on a drip?
There was no notation that she was a diabetic on the chart. Okay, it was for nutritional purposes, not for therapy. So the second thing is that there was a dementia care patient admitted to a hospital recently. And that individual suffered from dehydration-related dementia. So it came and went. And one of the important things that took place every day for that individual was to administer her own insulin injections. Because the hospital had a policy preventing patients from giving themselves their own injections, and were giving the injections for this individual, by the time she was discharged, she had been taught not to give herself injections and forgotten how to do it.
Hmm.
So I'm curious about hospital-induced incapabilities. Was that included in the study in any way?
No. No, and that's a challenge. I mean, hospitals are very gun-shy to let people inject themselves in the hospital, even if it's their
Yeah.
routine at
But
home. They're good. They just freak out about the.
that tells me that any patient that suffers with intermittent dementia and who is also giving themselves their own injections for whatever reason is going to be incapacitated when they're discharged.
Maybe.
No, not maybe. So I think there's some more work to be done on the admission process and some of the protocols for disabling people from being able to care for themselves upon discharge.
Yeah.
The bookends, if you will, of this process.
No, it's a challenge. All right, looks like we're about 10 minutes over, huh?
Okay. Thanks.
Yeah, thank you. Any wrap-up things, Ian, or others?
Are you going to cover the large scale implementation matrix? Or?
I'm happy to go through and do it. I guess I don't have any other things. All right, so this is kind of getting a crossroad of kind of what questions or what to be thinking about to try to speed the pace of change, and it's kind of a cross pattern of looking at Everett Rogers' diffusion of innovation and the Prochaska model. So it takes kind of the Prochaska model of saying, well, where is your client at? Are they in pre-contemplation where they're not totally really aware of what the problem is, or if it even exists, or they're aware of it, they're thinking about kind of how they could improve it, contemplation. They're actually fully engaged in preparing to take action, or they're actually in action and you're trying to kind of help them through that. And then taking that and flipping it across with Everett Rogers kind of lessons on how do you speed diffusion, looking at the 5 areas he had there of, can you show relative advantage of what you're asking people to try? Is it culturally compatible with, how they do things? Is it simple, or is it wildly complex and difficult? Is it something they can try on a very small scale? And then can they observe the results? So kind of taking that and making a grid out of the two is kind of what we've done and kind of talked through it at a point with the different people trying to do this work. So, if they're in pre-contemplation, relative advantage probably is not, they're not ready to talk about that at the moment. But, paying attention to kind of the multiple points of view, and the cultures and their acceptance of things with the compatibility, when they're in pre-contemplation, and talking through that with the client, of what you're asking them to do. So letting people inject insulin themselves when they're in a hospital setting and the nurse is scared that they're going to put her in jail for her license being at rent because what the patient did that they didn't have control of is going to freak them out. That's something you're going to have to really talk to, in a hospital to kind of move that practice along. If the organization is kind of in contemplation, they're thinking about it, you can start to articulate the advantages and disadvantages of, the actors and clients. Again, the person's been doing this for years, injecting themselves, that they know what they're doing. The timing with meals is great because they just ordered their meal. They know, there's some of the advantage to it. Understand kind of before being understood down below with the compatibility, listen to their misgivings, and that's kind of your most valuable guidance to start to think through how to help move this person along as a change agent. Again, when you're talking about stepping into action, that with the relative advantage, trying to develop the simplest, measure observation method you can to take advantage of being, there. So again, you're going to let this one patient start injecting their insulin. All right, we're going to talk about their glucose readings every time. It's there. Make sure that things look great. They're not overdoing it or underdoing it. Talk with them about how much they're using and make sure that seems appropriate to what you're thinking. And then compatibility, have the client communicate to peers. If you have a hospital that's already doing it, talking from the person from their how they got past it as a culture and sharing that with the people as they get ready to go into action. Then once you're in implementation, you can talk about the sharing the results and debriefing about what's working. And it's like, oh, wow, we've had 10 patients go through using their own insulin. We haven't had any issues yet. We did have a person we talked to about the dose they were using, blah, 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 and then starting to tell the story with data in the last part of that to kind of confirm kind of the relative advantage. You can start to make that visible to people. So that's kind of this idea of kind of, figuring out where you're at with your client that you're trying to get to change, and then thinking about, how you can kind of sell or talk through the challenges. If it's something you're asking them to do is not simple, be honest in your assessment of the complexity. If you're changing from paper records to an electronic record and the documentation's a nightmare and it just drives the staff nuts, there's not a simplicity kind of solution to that, but there are benefits to the electronic medical record, though many of the clinicians, feel very beaten up by the amount of work that takes. Finding someone already doing it and practice the communication from the point of view of the client. Develop the smallest scale change possible, even though it's not simple, that becomes a real challenge for people to kind of think through that, and then listen to the early feedback and fix problems right away with your implementation, and make people understand or believe that, you're going to take action when you see things, uncovered as you're implementing. Trialability, again, developing the smallest scale change. I think this so much reinforces the idea of small scale change when you start to think of it this way, with all of, what Everett Rogers has, researched and shown us, helps speed up adoption of something. It just seems to pop up over and over how important small scale change is in this kind of work, for people to kind of take advantage of the different things we do. And again, also listening to the concerns and taking action on them is so important, at each of the different stages. And with the implementation, start with the assumption that the change is wrong and the goal is better, not perfect. So you're not kind of saying we want you to do this and it's going to be perfect, but it's what's going to fail in it and how do we fail fast and fix whatever's going on with it. And communicate with staff the possibility of reversing the change if it's going to be not going to work when you're trialing it out. And then again, designing that measurement system so you can strive to make the observability as clear as possible and help the client understand what they're looking for as a demonstration for success, and make the measurement simple and fast and debrief right away. Don't wait and say, well, let's wait till we get a month's data to look at this. You really want to have that observability be something you can debrief that day or the next day about how did it go. Can we make and communicate this, until people become comfortable with, yeah, I've been looking at this and it looks like it's working, I'm okay with it. And you get that acceptance. An example of that, I think, would be in the state of Michigan with the surgical collaborative. They started working on, giving people just 12 pills for opioids, after the surgery. And when they started this, they were giving like 24 or 20 and asking patients how many they had left when it was done. And they were reporting that, oh, well, I took about 12 and I had 8 left. So okay, well, I think let's try ordering 12, and and if you'll know if all the patients are coming back to you saying, no, I needed more, it wasn't enough, that they overshot. And what was interesting is the follow-up calls they were doing after they dropped down to 12 is the people they started giving 12 to instead of 20 were saying, yeah, I only took about 8 and I had 4 left because that was good enough, where they weren't just taking 8 when you were giving them 20. And I think it really reinforced to the people how dramatic that you were kind of talking people into taking more by giving them more, and with acute pain that they were able to get off faster. So is this a helpful kind of way to frame this? It always seemed interesting to me every once in a while to go back to when you're trying to think about how do I want to get somebody to change, to kind of start to take the time to say, well, where are they at on pre-contemplation to implementation, and then what I'm trying to sell them on, where is the the leverage point with simplicity or triability or observability, from Everett Rogers. I think this whole project, the big project before there, really made me a fan of Everett Rogers and really think through kind of his whole diffusion of innovation kind of work as being really profound stuff. If you've never read that book, it's really worth it, even though it is a tome. But
I like it, Jack. I've not seen this before, and I think it's really good. Nice.
I like the approach. I'm curious how you got your foot in the door with the clinics, with the hospitals, in the first place. Was it through the professional organizations or the agencies, the compliance agencies, or how did you actually get them to open the door? I've tried approaching some of our local hospitals, and they're not interested in having anybody else help them with quality of patient care in any way, or even safety.
all right, so are you asking about me personally getting a job there, or are you
No,
talking?
no, I'm talking about any, how did the whole organization, appeal to hospitals to let them look at information in the hospital or practices? Because I found they're very, the whole concept of malpractice and the armies of lawyers that are waiting in the wings to sue these practitioners seems to be a massive barrier to improvement.
Well, CMS is the big gorilla that hands out a lot of money. And I think there was trust, because this was really kicked off by Don Berwick, and I think the health systems really do have trust in him. So I think that was very helpful. And they just kind of come off the 100,000 Lives program kind of there, and this was really taking that to the next level. So there was trust there. And I think part of that story, if these were new federal contractors doing this, that there was an intent to try to have trusted partners as the contractors, because a lot of these were hospital associations, which, are kind of the lobbying groups for hospitals, taking on a new role as kind of supporting this work. So they were seen as trusted partners. So I think that helped. I think some of the marketing of it, though, that got shut down because of political infighting. I think there was, at that point in time, there was a lot of energy behind patient safety and improving it. And again, I think it helped that, we had Don Berwick kind of, as the leader of CMS for the first 6 months of this, but he was there for a limited time. So there was a lot of the work that went into that to try to find the contractors to be trusted partners, to have them reaching out and selling it. And again, like I said, when it's CMS, they're big and important, and they're the government. So there was a little bit of compliance intimidation there too, though they were certainly reluctant to kind of share the individual level data to some degree, but like the infections, that all goes to, it's mandated that they share it with CMS, with the CDC, and CDC shares it with CMS anyway. So
relying on, we now have a lot of data sharing going on, but there's patient privacy protections in place. I'm wondering how AI might play a role in this going forward to help us overcome the secrecy and defensiveness of the hospitals.
Yeah, that's definitely gotten better in the last 10 or 15 years, but it is a challenge, and especially, even though right now it's not in favor to be looking at, disparities kind of work. That's something that has always been blocked to a large degree, because you have to have your denominator down to be able to split your denominator by, who the patients are. So like a lot of the infection data, it'd be really interesting to know, is there differences in, race, gender, whatever. But since you don't send a denominator in of here's all the patients who had a central line and what their gender or race or age were, you don't really have a way to do that. And you don't, even on the numerator hits, you don't have that, data there either. So that does hold back a lot of those kind of things, that you don't have kind of semi identified data. You can't really use PHI and for these things. And that does really hamper kind of a lot of that kind of work where you could learn a lot from, for claims data, you do have some of those kind of things. Like it was fascinating in a project I was working on, after this, that with COVID, readmissions for men got much worse. Women didn't change much at all. And things like that are interesting, and why, and lessons like that. And you don't have to necessarily violate patient confidentiality when you're looking at, hundreds of thousands of things, and 50,000 of them are men and 50,000 are women, and say, wow, these look really different, and that there's something there we should be thinking about. Why is it different? And
Yeah. I wonder how much of a role, I mean, it looked like the insurance agencies, the insurance companies were the winners in this thing. And you could also look at the lives saved as being a winning factor, but less tangible. I'm just wondering why the insurance companies aren't going after this more assertively if they stand to save billions.
Yeah, well, I mean, every patient who didn't get readmitted, they were a winner in this too. They didn't have to pay for the second one that the insurance company didn't, and they got to sleep at home. And and every patient who didn't get an infection, which you have no idea who they are, they benefited from it.
Yeah. I just think our legal systems and politics have got this so wrapped around the axle. I don't know how we're going to ever improve it.
Yeah, well, and the HIPAA is a challenge for a lot of this, and I understand why people would be reluctant, and there are things that pseudo de-identify kind of stuff, and again, most of the people who are even using it, they don't care about the individual. I mean, what I mean is they don't care data-wise about the individual where it's a violation. You're just joining these things together to look for your leverage points, and
yeah,
you're not doing anything that's going to put someone at risk because you're seeing their data. But I understand why people are scared of it.
Yeah. I'd like to know more in this area, but I've been on the device manufacturing side, so we're talking about customers.
No, I'm so thankful to Don Berwick for recruiting me to do this. It was the most fun thing I've ever done in my life, and it's
well, you can tell from the few stories
$1 billion again.
You can tell from the few stories I've shared that I have my frustrations with the whole, hospital environment people encounter. I'm not looking forward to being a patient myself. I'll probably be the worst. Can you imagine? I have an ounce of energy left in me to fight.
I ran risk management in a very large hospital for a couple of years and got to see all the worst things there because those are the things they investigate.
Yeah.
Hey Jack, a question. One of the blocks of the system of profound knowledge is psychology, and doctors are notoriously very egocentric or egotistical or very righteous in their way of thinking. How was that? How did you overcome that obstacle when you were implementing, or at least trying to get institute change in a medical environment?
Well, I think everyone wants to be safe, so it's not like you have somebody, well, very rarely do you have people that kind of have a inappropriate attitude, though. I think of Dr. Granatier, who was the lead of the medical specialties. And when they were talking around a safety thing, and one doctor kind of snidely said, well, they don't pay us to do this. It was so nice to see, Dr. Granatier just take that person out and just rip them a new one. It's not something I could do, but I mean, the doctor, look, this is what we're doing this for. and I think you do generally have that support. People want to be safe. They want to do a really good job.
Yeah.
And there's some level of shame when things don't go as they should, but um, and when things generally are making things better, that they're willing to put in some level of investment of their time and energy to do that. I mean, you can't overburden them. I mean, there's a limit to
Yeah.
how much you can ask of people, but I think if people believe it's gonna work and it's gonna make a difference, they're usually pretty willing. They're very rarely do you find people that are just a jerk and not going to invest when they think it's going to actually help their
Yeah.
patients.
Okay.
Now they might not believe it's going to help, and they'll give pushback, and that's important to listen to.
Yeah.
You know,
I noticed one of the blocks that you just had up on your slide was the start with the assumption that the change is wrong, and the ability to go back to the prior state. I think gives people a certain level of comfort before they start exploring change. That's typically not how change processes work. So that might have been a big factor in giving people a safe space to move forward, knowing that they can step back if things don't go quite right.
well, I can tell you a lot of times with this, when you listen to somebody tell you their theory about the way it works, and then I would go back and try to pull the data and say, is there any validity to it? And a lot of times you kind of come back and say, well, here's all the data, and it doesn't look like your theory holds any water.
Yep.
And sometimes if it's a very vocal position or whatever, you do that in private after the meeting. You pull the data and you say, can I just have a little meeting with you, just one-on-one? And here's all the data. I listened to you. I pulled it, and it doesn't look like what you think's going on is what's going on. And that can be very effective. You can't do that in public in front of other people and shame them. But if you take them seriously and listen to what they say, and then you try to pull data together to do it, they're usually they get out of the way at least then.
Yeah.
And sometimes you have to have that pain in the ass person, where you're like, we need them on the team because it's better to the whole Lyndon Johnson quote, it's better to have them in the tent pissing out than outside the tent pissing in. So sometimes you really need to pull those people in,
Yeah.
and say, well, we want you engaged in this, and
So you were able to overcome that threshold of ego then.
well, not always, but yeah.
Yeah, but I would just imagine that's slightly higher for doctors than other professions. So,
What Jack, what your comment reminds me of is with the people you're talking about that can be difficult is sometimes they're speaking on behalf of others who are afraid of speaking.
Occasionally, yeah.
Which means as long as they are, if I can use the word rational, I mean, if they're telling you the sky is green, well, it's different. But I find is if they're coming from a good place, then the benefit, and you have to get them inside the tent. There's no doubt about that. But I often wonder is I'd rather have people speak up and tell you than quietly walk away and just give you half-hearted. So it can be challenging to have them, but what can be even more challenging are the ones who are quietly disagreeing and undermining.
Undermining, I was going to say, is the big, threat there.
Yeah.
They go out and do a million different little things throughout their day to undermine your effort. A word here, a word there, an action here, an action there.
Yeah.
I do not remember K Diggs, no. So, but I have an interesting kind of a story there with a group that was just one of the most frustrating I ever worked with. And it was this three of them, the leader of the dialysis organization at Henry Ford, the nephrologist who was like, thought he was the smartest man in any room ever, really, but and challenging personality. And then the vascular access surgeon who was kind of an ER kind of a person. And the three of them, and we were trying to work through a number of kind of safety things with dialysis. And we ended up doing a failure modes effects analysis, kind of working back through it. And they were so dissonant, it ended up scoring it the 3 different ways from the 3 and then trying to facilitate the conversation with them. And even at that, I was just pulling my hair out, and I ended up saying, I got to walk away from this. And then 2.5 years later, they won an award for the work they did. And they went to, the CMO and said, Jack Jordan was the one who really led us to this. And it was like, I would thought they were never going to get anywhere. And it was just pulling my hair out, but it was enough to get them started. And then they kind of carried on after I kind of said, I'm going to want to murder one of these guys if I keep going at this. And then it was enough to get them to go, and it worked, So sometimes, it's the people that you're frustrated with the most. If you're getting traction with their thinking and are taking it serious, they can run with it and maybe just get out of the way and let them,
Yeah, I think if they're even willing to have a conversation with you about it, even if it's an argument, you've got a little bit of traction. I've unfortunately encountered people that won't even listen.
Yeah, well, those 3 had very different points of view from the 3 different aspects of, the process, but I think they ended up getting traction together once I got out of the way. So, I don't know.
That's good. And they gave you credit later.
Yeah, which I was shocked. Yeah, when Dr. Conway came to me and told me that, it's like, really? They gave me credit?
Sometimes I used to wonder, did they give me credit or did they set me up to take a fall for the blame if it doesn't work? Could go either way. Yep. No. If you ever need help, let me know.
Well, I'm on the government contractor side now, on the dark side. So, I work for American Institutes for Research.
I'm even on a darker side. I'm a consultant. So, private.
So does anybody have any other questions for Jack?
Pleasure seeing you, Jack. Look forward to seeing you
Mike. Haven't seen you
in California.
Time. You're out in California?
No, I said I look forward to seeing you in California.
Oh, well, I don't know if I'll get out there this year, but let's see.
Oh, okay. I'm in Connecticut.
All right. I'm still in Ann Arbor.
Yep.
Yeah. Well, thanks, Jack. This was very thought stimulating, and I really think that kind of matrix that you've come up with is a genuine innovation and thinking about large scale change. So I think that's pretty neat.
Thank you.
I like the model too. Very good.
Nicely done.
Really kind of a mashup of models, but it works.
All right.
Okay. All right. Well,
Okay.
thanks.
All right.
Thanks, everybody.
Have a great rest of your day.
I'll get this posted and I'll send everyone a link.
Thanks, Phil.
Thanks, everybody.